Welcome everyone to today's webinar. I'm Laura Lubbers and I'm the Chief Scientific Officer of Cure Epilepsy, and I want to thank you for joining us today. Today's webinar is entitled Identification and Treatment of Autoimmune Epilepsy and is intended for everyone, including persons with epilepsy and their caregivers. Our body's immune system is what protects us from harmful viruses, bacteria, and more. Autoimmune encephalitis refers to a condition that occurs when the body's immune system mistakenly attacks healthy brain cells, leading to inflammation or encephalitis of the brain. As a part of the immune system's response, the body produces antibodies that often target different receptors in the brain, which leads to different forms of autoimmune encephalitis. Symptoms of autoimmune encephalitis may include seizures, memory loss, cognitive problems, and impaired speech. Autoimmune-associated epilepsy may also result, and it's important to diagnose because this type of epilepsy does not generally respond to typical anti-seizure medications. Instead, immunotherapy is often used to treat people with this condition because it reduces inflammation in the brain. This webinar is the first of Cure Epilepsy's 2022 Leaders in Research webinar series, where we highlight some of the critical research that's being done on epilepsy. Today's webinar, like all of our webinars, is being recorded for later viewing on the Cure Epilepsy website, and you can also download transcripts of all of our webinars for reading. For over 20 years, Cure Epilepsy has raised millions of dollars to fund epilepsy research that supports our mission, which is to find a cure for epilepsy by promoting and funding patient-focused research. Cure Epilepsy provides grants that support novel research projects and that advance the search for cures and more effective treatments. To date, we've raised over $85 million to fund over 270 research projects from investigators around the globe. Today's webinar will help viewers understand the difference between paraneoplastic encephalitis, which is an inflammatory disorder of the brain, and autoimmune encephalitis, as well as the difference between acute symptomatic seizures related to autoimmune encephalitis and chronic autoimmune-associated epilepsy. Viewers will learn about the characteristics and biological mechanisms of autoimmune encephalitis and when to suspect autoimmune-related seizures in epilepsy. This webinar is presented by Dr. Steven Van Herentz, an assistant professor in neurology and medical education at Northwestern University Feinberg School of Medicine. His practice focuses on the medical and surgical treatments of epilepsy, with particular emphasis on the treatment of medically intractable seizures. His clinical research interests include neurostimulation, identification and treatment of autoimmune-associated epilepsy, and new onset refractory status epilepticus, also known as NORS. Additionally, Dr. Van Herentz is deeply involved in medical education and currently serves as the Director of Medical Student Education and Neurology. He also serves as the co-chair for the Neurology and Neurosurgery Health Equity, Diversity, and Inclusion Committee at Northwestern. Before Dr. Van Herentz begins, I'd like to encourage everyone to ask questions. You may submit your questions anytime during the presentation by typing them into the Q&A tab located on your Zoom panel and then click send. We'll do our best to get through as many questions as we can. We do want this webinar to be as interactive and informative as possible. However, to respect everyone's privacy, we ask that you make your questions general and not specific to a loved one's epilepsy. So with that, I'd like to turn it over to Dr. Van Herentz.
Hi, everyone, and thank you, Dr. Lubbers, for that warm introduction. And thank you, everyone, for having me. I'm very excited to be here. And we're talking about a topic that's very important to me and my clinical practice and my patients. So without further ado, we'll get started. Up there. Okay. And sorry, one second, getting used to advancing the slides here. So the learning objectives, actually, Dr. Lubbers went through pretty much already, so I won't spend too much time on the learning objectives, and instead we'll kind of get started. And I do want to have a few disclosures because unlike other treatments in epilepsy, autoimmune epilepsy, autoimmune encephalitis actually has no FDA-approved treatments. And so I'll be discussing treatments that are more, actually, they're all off-label usage. And I think we'll likely be doing a follow-up to discuss full treatment options, but we'll start with a case where I will discuss some treatments for that particular patient. So I think it's great to put all of this in the context of a particular patient of mine. And he's doing very well now and knows that I am presenting him individually. And so this is a case of someone who had more subtle kind of presentation. So he is a 69-year-old gentleman. And this is back in 2014. Where he was noted to be very confused. A neighbor initially saw him and he looked like he had just kind of woken up and seemed sort of out of it. They have a cottage up in Wisconsin, and so his wife came back from their cottage and found him very confused. She was clearly very concerned about this, and he was unable to remember the deaths of like family members, like his parents had both passed away and he couldn't remember that. So she took him to a local emergency room. It was not Northwestern, my hospital, so I have not met him yet. But this was at another hospital where at first their initial concern was, had he had a stroke? And so they got a CT and MRI of his head. And, you know, when that came back unrevealing, they did an EEG. And for those of you unfamiliar, that's, you know, the electrodes on the head looking for evidence that you might have seizures. So he continued to have difficulty. So essentially he was discharged from the emergency room. There was no stroke found. There was no evidence of seizures found at that time, but he wasn't any better. And in fact, he just continued to get worse. He had difficulty with his memory. He was unable to work effectively anymore. He actually had to retire from his position and take early retirement. He continued not to remember that his parents had passed away. He stopped sleeping as well. He would stay up till about 5 a.m. when he would always be in bed by midnight. He was losing weight, and his advanced, what we call ADL, activities of daily living, started to decline. He wasn't able to do tasks around the house, pay bills, like more advanced type tasks. He was just overall declining. And in addition to that, his behavior and mood were also changing. He was more irritable, he was aggressive, he was always like a very kind man, and he actually left bruises on his wife's arm. And then he was also more affectionate than usual. He reported some low and depressed mood, and he had also become very OCD. He couldn't leave his house without double checking things anymore, which was not his previous behaviors. And overall, he was just, as his wife put it, a different person. So in addition to these behavioral changes and cognitive decline, he was also having these episodes, which they called panic attacks. They believed it actually started maybe a few years before the onset of the confusion, but now we're happening up to 20 to 30 times per day. And when digging deeper into these panic attacks, they described them, he would breathe deep, breathe heavily, and words were hard to get out. And then his face would kind of get pulled into this kind of frown. And to them, it looked like he was about to cry. And it would last just a few seconds. And they thought it was triggered by when he realized his memory was poor or he was forgetting something. They also noticed he was getting goosebumps a lot, very frequently. And he would start to breathe, and then it would look like he was going to cry again. When asked about it, he said it would feel like almost like an adrenaline rush. Other than that, like, he really didn't have a significant medical history, social history, or family history. And on his exam, it was fairly unremarkable. His temperature was a little low. When you examined him on his like basically mental status exam, he was a little pressured, meaning that he was very talkative. I remember he was very fixated on talking about apples, for instance, and he would really just talk about whatever he wanted to talk about and had to be constantly redirected. He really couldn't form memories. I would have him try to memorize like 3 words, and as you can see here on this exam, he could remember 1 of the 3 words at 5 minutes. So his memory was quite poor. And during like meeting him for the first time, he had several of these episodes of like rapid breathing and his mouth being pulled into a frown, and then kind of forgot what he was talking about. right, and like asked like what to do before the spell. The rest of the exam was really unremarkable. Um, so, I know most of you or all of you are not physicians, but what is the differential? Meaning, like, what is wrong with him? Does he have early dementia? Is this all like, psychiatric or behavioral? And then what do you do if you're a family member or if you're a provider? What do you tell the patient? What do you tell the family if you're a caregiver? And what is his prognosis? Like, what are you going to do? So maybe we'll circle back to him, but let's review this sort of workup and how is someone who deals or treats these types of patients, how we approach this. So before that, I think it's good just to talk about what are these antibody-associated autoimmune disorders, because there's a lot of terminology out there if you're on Google, and there are a lot of overlapping terms. There's autoimmune epilepsies, autoimmune encephalopathies, autoimmune encephalitis, autoimmune dementia, and really they all kind of mean the same thing. They're antibodies that are directed towards functional proteins that are in the nervous system. And wherever they are affecting the most is the symptoms you're going to see. So, the brain, we try to separate neurology and psychiatry, but they're really inseparable because they're one organ, they're the brain. So you can get lots of dementia, psychosis, you can get seizures. You can also get movement disorders. If it is affecting blood vessels, you can get strokes. And so there's a lot of these overlapping kind of syndromes, and you may have more than one kind of bucket. So this has been a field that has been rapidly expanding, and our knowledge of it has been rapidly growing. So when you look at autoimmune neurology from the 80s till now, it's really an exponential growth in the amount of literature that is available. So now let's talk about some other kind of definitions, things that get thrown around a lot. There's an entity called paraneoplastic versus non-paraneoplastic, and then limbic versus non-limbic. So let's go through what people mean when they say these types of terms. So when people talk about paraneoplastic conditions, this really just means neurologic disorders associated with some underlying cancer, but caused by mechanisms that are not, like for instance, if someone has breast cancer and the breast cancer is spread to the brain and is now causing weakness or even seizures, you don't typically refer to that as paraneoplastic. It's usually like directly neoplastic, and you would actually call it tumor-related epilepsy as far as the seizures. So it's not usually referred to metastatic or like metabolic, nutritional from the cancer, infections related to maybe some chemo or immune suppression from the cancer. So it's usually reserved that it's related to autoimmune disease. And what our thought is on that is that the immune system is really trying to attack the cancer, but in doing so ends up attacking normal tissue as well. So then there's the limbic system. So what does it do? And I actually teach this lecture to our Northwestern medical students, and I give them this little mnemonic called HOME, H-O-M-E. And it really kind of defines what the limbic system does. And a limbic system is really like a very old part of the brain. We call it the archicortex for those more pathologically inclined, but it really does. You have the hypothalamus, which is really in charge of like homeostatic functions, like autonomic with like blood pressure, heart rate, temperature control, neuroendocrine kind of control, hormones, pituitary. In fact, I had one patient who really presented, she was 27 and looked like she was post-menopause. She had stopped having periods, and that was one of her initial symptoms from her autoimmune encephalitis. And she would later go on to have multiple seizures, which is how she came to me. But really, one of her first symptoms was really the lack of periods. And so, like I said, a lot of these things come in patterns and affecting multiple parts of the brain. Olfaction is, your sense of smell. And people don't ever really complain of that, but it is involved in the limbic system. The two things that people tend to notice the most is their poor memory through an area called the hippocampus, and emotions and drives from the amygdala, both of which are very much affected as part of the limbic system. But autoimmune encephalitis doesn't have to be a limbic encephalitis. Limbic encephalitis is essentially these structures. And so if antibodies are attacking these structures, it's a limbic encephalitis. If they're not, then it's not limbic encephalitis. But it can be other forms of encephalitis, because encephalitis really just means brain is inflamed. Encephalopathy means the brain is not functioning well. And so it's important to just kind of recognize these terms as overlapping, but also different. And so for those of you who like more pathophys, I'm going to go through kind of two arms of our immune system that will kind of help understand, because this does affect how the treatment is, how the diagnosis, and like how severe the actual syndrome is. So let's just take a look at how these, like who gets autoimmune encephalitis, who gets autoimmune epilepsy. And so there's really three main camps. There's those that are paraneoplastic, like we talked about, like maybe they have an ovarian teratoma or a thymoma in their thymus, and your immune system is trying to attack that. There's also links to certain viruses like HSV encephalitis. There is now a very clear link with HSV encephalitis leading to another autoimmune condition called anti-NMDA receptor encephalitis. And that's been very well documented at this point. So there's definitely viral prodromes as well. And then there's idiopathic, meaning we have no idea how it happens. And some of these patients, having had a lot of these idiopathic, some of them just come from, there might be some sort of genetic predisposition, like lupus or other autoimmune diseases run in their family, or they have other autoimmune conditions as well. So, it's unknown exactly what caused it, but sometimes there does seem to be some risk factors. And so now let's break our immune system into two pieces. You have B cells and T cells. T is in Tom. So B cells are bone marrow derived, that they become these cells called plasma cells. And plasma cells then make antibodies. And so antibodies are supposed to recognize foreign things, like for instance, like viruses or bacteria. But if they're making antibodies that are autoreactive, meaning recognizing your own neurons, they can bind to things like, for instance, an NMDA receptor or something on the surface of a cell that then is activated with an inflammation and can get destroyed, leading to sometimes damage of those cells. And those are B cell or cell surface antigen targets, as opposed to this other side, T cell, which is predominantly T cell mediated diseases. Now, when these little green antibodies hit things, they can destroy it. But what if the protein the antibody's targeting isn't outside the cell at all? Then these antibodies actually can't reach this protein. And this happens with some of these intracellular targets. And so when you see antibodies derived against intracellular targets, the antibodies aren't so much toxic themselves, but more of a marker that the cell is being injured. And it's probably being injured by the cytotoxic T cells. So B cells, these antibodies, like if you take these red antibodies and you take them from one mouse and you put and who's sick with, let's say, NMDA receptor encephalitis, and you put them in a healthy mouse, that other mouse will then also become sick because these antibodies are just so toxic to the brain. Well, these antibodies, like I said, are markers. They can't actually reach their target. So they really aren't that damaging, but these diseases are still autoreactive with these T cells and still is causing a lot of damage. Okay, so moving on. My little arrow here. There it goes. All right, so I'm trying to be a lumper and not a splitter, but there's a lot of different antibodies and we're discovering new antibodies all the time. So, oops, now I advanced too far, but so going back one slide. I'm sorry, I think there's a lag. So now I'm reversing because I hit the advance button a few too many times. Oops, and it's still advancing forward. Okay, so here we are. So, oh, now we're back to there. But I'm going to just stop hitting it and I can talk from memory. I know what the slides say. So the cell surface ones are going to be examples like NMDA receptor encephalitis, maybe you've heard of voltage gated potassium or LGI1 encephalitis. All of those are the cell like surface. And there it goes. So like voltage gated calcium channel, all of these are these cell surface where the antibodies are directly toxic, as opposed to the intracellular ones. And the intracellular ones are like anti-Hu, there's TOD, there's CRMP5, amphophysicin. There's also GAD65. And with the exception of GAD65, almost all of these are associated, highly associated with cancer. So the intracellular ones are very frequently paraneoplastic, as we were talking about, related to an underlying malignancy or cancer. Okay. So now let's talk about seizures, since this is cure and the E is epilepsy. So seizures are a well-recognized prominent manifestation of autoimmune encephalitic syndromes. So patients with systemic autoimmune disorders are at increased risk for seizures. So the term autoimmune epilepsy was initially suggested as a concept in 2002, but there's been like an emerging body of evidence suggesting the autoimmune mechanisms in a subset of patients with epilepsy. So the International League of Against Epilepsy, the ILAE, now has a category of an immune etiology for epilepsy. However, many of the patients with cell surface antibodies that we were just talking about can actually reach complete seizure freedom after treatment. And so this is kind of counter to the whole concept of epilepsy, which is this enduring kind of predisposition to unprovoked seizures. So in response to that, in 2020, this was further divided into two broad categories. You have acute symptomatic seizures secondary to autoimmune encephalitis and autoimmune associated epilepsy. And the acute symptomatic seizures secondary to autoimmune encephalitis are typically those cell surface antibodies like LGI1, anti-NMDA receptor. And it's thought that these antibodies are antibody-mediated ictogenesis because those antibodies are toxic in themselves and lead to seizures. And if that immunotherapy is started quickly, they can avoid having to stay, like they could be cured essentially of epilepsy long term. Now, that doesn't always happen, particularly, and I will show in a slide later, if there's a delay into immunotherapy, you can lead to damage to the brain itself and can still have seizures, but you have the possibility of kind of more of a cure. While autoimmune associated epilepsy is more complex. This is often like GAD65 or those intracellular antigens, and they have persistent epilepsy after acute autoimmune encephalitis. And it's thought that their epilepsy is due to ongoing, like basically brain inflammation, but also structural damage as well. So they're kind of getting it from both sides. And they're usually very medically, or they don't have to be, but often, especially if you make it to my clinic, their anti-seizure medications are often ineffective. They might have had epilepsy surgery with an incomplete response, immunotherapy usually with a poor response as well. So they're very difficult to treat, and you really kind of throw everything at them. But at the end of the day, pharmacoresistant, meaning that medications, at least 2 medications have failed, is not uncommon. And they often will have cognitive deficits as well. Okay. All right, and this is just kind of showing that these acute symptomatic seizures secondary to autoimmune encephalitis. So the green line is when the first seizure stopped, the red line is when their last seizure stopped, and the blue is when they were able to come off seizure meds altogether. And each little notch is a year. So essentially, those with cell surface in the study, 25 of them, did amazing. The ones with the intracellular didn't, essentially, that they continued to have seizures. You weren't able to get them to stop. Okay, so let's just talk about what do autoimmune related seizures, are they different than other forms of epilepsy? And how are they different? So one key thing that kind of might set you off is their early medical intractability, meaning like from the start, the seizures were very hard to control. They usually lack other typical epilepsy risk factors, such as like seizures with high temperatures as a child, or like family history of epilepsy. The seizures tend to be very like high frequency, but short duration. Not always, but quite often. And they won't have a lot of that post-ictal confusion. Sometimes like first onset of status epilepticus or continuous seizure activity, that's common in this GABA A and B autoimmune encephalitis, multiple seizure types as well. So typically, you know, if there's a structural lesion or another types of epilepsy, it'll be one type of focus and one semiology, but they'll have multiple. EPC is called epilepsia partialis continua, and that is like a clonic seizure. Like it could be really small, like just like a finger going back and forth, but it's persistent and hard to treat. That can definitely be, it's not always autoimmune. It's usually like from a structural lesion like stroke or brain tumor, but particularly if no clear lesion, mitochondrial or you should think mitochondrial or autoimmune as well. And then there's specific antibody associations like LGI1, which is facial brachial dystonic seizures, where they get this kind of either like face gets cloned down or arm, and they're really fast. And I'm going to show you a video of that. GAD65 is associated, I definitely have patients with musicogenic epilepsy. They often have a very distinctive music trigger that can give them this reflexive seizure. And this kind of perisylvian semiology in this area of the brain that gives you a lot of different, it's actually the next slide if it advances, but can give you kind of like auditory or language dysfunction, autonomic with like elevated heart rates, language difficulties. So very unique, which aren't always you know, common epilepsy types. And so this was looking at all these different types of perisylvian, and this is from Gillander in Australia, and looking at these, and almost all of these patients in the study had anti-GAD encephalitis. So let's just look at a patient with facial brachial dystonic seizures, just because you can kind of see one. And as I play this, you'll see they're very brief. So he sits up in the chair here, and it's going to be, and then he has this brief kind of tonic contraction of his arm there. And then it's done. And it can be of the leg too. They can fall. It might just be the face, or it can be all of them. They usually don't have much of an EEG correlate, but if they do, this black is really just the EMG. That's the muscle contraction itself. But sometimes you see this kind of attenuation or like loss of kind of frequencies. So why is this such a difficult diagnosis to make? Well, is it rare? Well, it's as rare as much as we look for it. So this is from Mayo Clinic, where they actually looked at the prevalence and found that it was comparable to infectious encephalitis, except this is increasing over time. And I don't think it's because it's a new disease. I think it's because we're looking at it for it more. So it's probably not as rare as we originally thought. Heterogeneity of clinical presentations, well, different antibodies affect different parts of the brain, so they're going to have different presentations. But the more we learn about it, some of these antibodies have very specific and very stereotype type presentations often. Send out panels. This is true. There's a lot of different send out panels from a lot of different companies, and different labs can have patents and things. And so it can make it very hard to send a comprehensive panel. Not to mention, you can have insensitive false negatives. You can also have positive reactions to brain sections, because not all the antibodies that we even know of are commercially available. There's a delay in getting the results. It can take like 10 to 14 days. And there's antibody negative disease. We're kidding ourselves if we think we know all the antibodies at this point. You know, NMDA was discovered in 2007. From some of the many of the people on this call, that wasn't that long ago. And that's one of our best described. So we're constantly discovering new antibodies. And then there's low titer or false positive, just being these kind of low, like basically not a ton of antibodies, but it's hard to know what to do with that. For instance, you can have GAD65 in the blood, which isn't as helpful as, you know, if you see high titers in the spinal fluid. And they can mimic other diagnoses. So these are kind of clues to clue you into an autoimmune etiology, like, you know, kind of things like we talked about our patient in the beginning of this, like change in baseline neurologic function, kind of fairly rapid onset for like an Alzheimer's or dementia. It's pretty fast. Can have a fluctuating course. They might have other systemic markers of autoimmunity, like an ANA or TPO antibodies, which are in thyroid. They might have a malignancy, or they have an inflammatory CSF findings, abnormal EEG or MRI. So this is a study that we did at Northwestern looking at these TPO and ANA antibodies. And we basically found that, you know, while they're not specific in any way, they were really elevated in our patients. And for those with, you know, having present, it was 45%, 35%, and 32% of the patients tested. And so basically, the prevalence of these antibodies has been previously reported in disease-free populations. So, you know, it is interesting that, you know, having 3 of 3, or even just having 1 of 3 positive was actually like fairly sensitive, even as much sensitive as the MRI at times. So, so while not specific, they can help point you in the right direction. So while this can be overwhelming, I'll walk you through kind of an algorithmic approach of how I approach these patients and how I teach my medical students and our residents to approach these patients as well. And then we'll circle back to the clinic patient that I presented. So in the serum or the blood, I usually check those, you know, paraclinical markers like an ANA or TPO, and then I'll get a spinal tap. I'll look and see if there's anything inflammatory, and I send this panel out. And then regarding, I'll get brain imaging and look for any swelling in the brain. I look at the EEG, if there's any slowing spikes. And then I often get a PET of the brain too. And then I screen for any underlying malignancies. And so going from there, I just want to give you some caveats too, that panels are, there are lots of different panels. So I try to encompass as broad of a panel as I can, but looking at specific symptoms, for instance, MOG, which you might see in white matter of the brain, little lesions, and can also present with seizures. GFAP can look like a meningitis. And so I, you know, depending on the case, I'll add on additional antibodies or additional panels as well. I never order a single antibody though. I always order a panel because the symptoms can be overlapping. And, you know, for instance, they might have LGI1 with those facial brachial seizures that we looked at, but maybe they have some other antibodies too that are more linked with cancer, because you can have more than one antibody at a time. So, and I usually try to use labs that are have research as part of them too, especially if the antibody panel comes back negative, they can look at like mouse brain and see if there's any autoreactivity at all. Essentially, you know, it's also important to look at the blood and the spinal fluid, because there's certain antibodies that are only available in one or the other. And for instance, NMDA can be negative in the blood, but it's positive in the spinal fluid. And LGI1 can be positive in the blood, but it will be can be negative in the spinal fluid. So you really kind of need to get both. And you have to be aware, like one thing that is that there's not always a ton of inflammation in the spinal fluid. And this is from Quebec, where they looked at the spinal fluid, and in a quarter of them, there was nothing inflammatory in the spinal fluid. And so to help us, there are these predictive tools to help find if these are autoimmune or not, and what is suggested. And so this is the APE and the right score. And they looked at patients with epilepsy of unknown etiology and found which ones actually had autoimmune encephalitis. And they developed this scoring system. And they're really not that different. And I won't go through the whole thing, but it's really kind of what we're talking about. But I'll just score it with you, that patient we were talking about. So new onset, rapidly progressive mental status changes that developed over 1 to 6 weeks, or new onset seizure activity within 1 year of evaluation. So that would be the patient I discussed. So that's a point. Neuropsychiatric changes, agitation, aggressiveness, emotional ability, that would be a point. Autonomic dysfunction, sustained tachycardia, which is high heart rate, blood pressure falls. He didn't necessarily have any of that, so we did not get a point. He didn't have a viral prodrome. So those panic attacks, I don't know if you noticed in the presentation, but they actually were all facial-brachial seizures. So from initially he was having 20 to 30 of them a day, and his face would get pulled down. They really weren't panic attacks at all. They were actually all seizures. So he actually gets a total of 5 points. Facial dyskinesias you see with NMDA receptor encephalitis, seizures refractory to 2 seizure meds. He didn't know he was having seizures yet, so you can't really give him a point yet on that. But and then he hadn't had a spinal tap or follow-up MRI yet, but he was already at 5 points. And even just based on that, with not even being able to score the whole thing, anything greater than 4 is a high likelihood that they will have an antibody positive. And so this isn't as popular of a paper, but I do like to use it. It's by the same author as the scoring, that essentially over 4, even if you don't have the antibody panel back yet, that it's worthwhile to just try an immunotherapy trial at that point. Okay. So good. So let's just talk about seizure medications real fast, because as we talked about seizure meds, autoimmune epilepsy is characteristically very resistant to anti-seizure medication. Interestingly, carbamazepine was found to be more effective than levetiracetam in reducing seizures in LGI1 encephalitis. I don't take too much out of that, except that sodium channel blockers tend to be good for focal epilepsy, so I do try to use them in autoimmune patients, but recognizing that they need immunotherapy as well. And I'm just going to show this because I think this is a very meaningful diagram. And this is looking at those facial-brachial dystonic seizures. And this is, the red is administration of seizure meds alone, and this is seizure meds with immunotherapy. And this is the ongoing seizures. And you can see there's a huge drop-off with immunotherapy as opposed to seizure meds alone. And this is, I think, the most startling, in that if you look at delay in start of immunotherapy in days and the likelihood of getting rid of the seizures, essentially it drops. The longer you wait, the less likely you have that they will go away. So let's conclude with the case that we were talking about. So just to recap, so this gentleman is in his 60s. He had a sudden onset change and cognition. He ended up having to retire early. He had developed OCD. He wasn't sleeping at night. He was having very frequent panic attacks. And really those panic attacks, he would have, like, he would look, his face would look like it was pulled to a frown, and he would almost, sometimes he'd have goosebumps, and he would think it would be like, feel like an adrenaline rush. And so when I met him, unfortunately, this was months into this course. And so when I met him, I immediately was very concerned. He also had low sodium on his labs, which you can see with the specific antibody. And it did come, oh, and then I put him on EEG. And for those of you who've seen EEG, he's having, in this one, he's having a seizure from his right temporal lobe. And then he had a seizure from his left, and then another one from his right. And so basically he was having lots of seizures. And so we initially started, and if anyone remembers the antibody, I don't think you can answer. I usually give this live, these types of lectures, but it is LGI1. It did come back voltage gated potassium with LGI1 encephalitis. And he was negative for cancer in his malignancy screen. So we did initiate treatment for him. I started something called plasmapheresis to get the antibody washed out. We got steroids and intravenous immunoglobulins. And he's actually doing amazing now. He actually had to be on antipsychotics for a while, which he's now off. And he was on valproic acid, but he wasn't tolerating it, and he switched over to levetiracetam. And if you remember, with his type of antibody, you can be cured of seizures long-term, but with him, he continued to have sharp waves on his EEG, so he has remained on 500 milligrams twice a day, but has had no further seizures, and he's actually off immunotherapy now as well. And so that was pretty much the lecture. I do want to thank our former fellow and Sebastian, who is at Mayo Clinic, and Claudia, who's at NYU. And that's pretty much it. I can open for questions.
Great. Thank you so much, Dr. Van Herens. That was a lot of information, and we've got a lot of great questions. And we know that you've got more, so we're hoping that we can bring you on back to share more information. But let's start in with the questions. So there's some great ones here, and I too am anxious to hear the answers. So first question, could infections like Lyme, Babesia, or Bartonella be possible causes?
So that's so any infection's possible. So I actually did my training in Massachusetts, so I've definitely seen lots of Lyme. But you know, Lyme, one, it's very inflammatory CSF typically if it's invading the spinal fluid. But post-infectious, it's always possible, but at this point there is no links to any bacterial type infections. The only clear link at this point that I'm aware of is herpes simplex virus and NMDA.
Interesting. Okay. Thank you. I'm sure there's more to learn though there.
There's definitely more to learn.
Can you tell us about seizures that originate or localize in the brainstem?
So that is more of an animal model thing, but but there definitely is autoimmune encephalitis that also very much attacks the brainstem. I'm almost like, how much time do you have? The brainstem is a very condensed area of the brain, and so you can have a lot of different symptoms. They do, in one form that attacks the brainstem, they do get myoclonus, but they have a lot of sleep dysregulation as well. And deeper, a lot of times when things are involving deeper areas of the brain, though, seizures are not a prominent manifestation. It tends to affect more like movement disorders and coordination, just because that's what that area of the brain does more than actually seizures themselves. So I typically actually don't see a lot of those patients, but people tell me about them, but they tend to see my movement disorder colleagues more.
Interesting. Again, so much to learn about the interconnectivity of the brain and how they manifest, yes, in terms of seizures or other changes. So could autoimmune epilepsy manifest itself as a focal seizure? I think you've kind of addressed this, but
it's almost always focal seizures. When they generalize, it's secondarily generalized. So as opposed to like a genetic generalized epilepsy, which affects both sides of the brain at the same time. Even when they have a full generalized convulsion, it's usually secondarily generalized.
Okay, interesting. Here's another question. Do you see intracranial hypertension in your patients?
I'm curious why that question was asked.
We've got a great audience.
That's an interesting question. So there's forms of idiopathic intracranial hypertension, which I definitely have in my clinic as well. But don't, and maybe there's some link that they're alluding to, but I don't know of any link to autoimmune encephalitis, especially if they had pre-existing hypertension. That being said, when your brain's inflamed, you can get rises of intracranial pressure for sure.
Okay. So here's a more treatment-related question. How close are we to getting IVIG infusions FDA approved?
Oh. And I'm curious if this question is geared more towards to get insurance to pay for it, which is always a battle that I do in my clinic. And so there was a trial with IVIG at Mayo Clinic for LGI1 encephalitis versus placebo. So IVIG is probably more on its way than many others, but I'm not involved in the FDA process, so I actually don't know.
That's fair. Maybe we can come back with an answer to that. Here's another treatment-related question. Is there a next step if immunotherapy and anti-epileptic drug treatment does not work, or do we have anything at the moment, or do we not have anything at the moment?
So this would be more of an, so I never give up, really. So there's lots of forms of immune suppression. So when we were talking about B cell and T cell mediated therapy, so for instance, I used, it was in the newspaper and she signed a media release, but we had a patient with NMDA receptor encephalitis who was in a coma for about 5 months, and we could not get her to wake up. And we used plasmapheresis, IVIG, steroids, rituximab. She even got a chemo drug called cyclophosphamide, and nothing touched her, essentially. And so we used this drug, a newer chemo drug which had been used in Europe called bortezomib, which is chemo for multiple myeloma, which is a B cell malignancy. And she woke up from that. So there's lots of different therapies. I didn't talk about ketogenic diet either, which seems to have anti-inflammatory properties to it as well. And there's also anti-interleukins to like anti-IL-6, IL-1, which gets used in those kind of Norse and fires cases, if people know what that is, but that is a whole separate lecture. But so what do I do if initial therapy doesn't work is I try more. But that being said, sometimes you do palliative surgeries, like if one area is structurally very damaged, you could consider surgery or neurostimulation too, with like vagus nerve stimulators, or even invasive neurostimulators have been used in patients that are autoimmune as well.
Okay,
so you don't give up.
Right, never give up. Never ever give up. And we also don't give up on the research. We keep looking for solutions. So I'm glad you brought up the ketogenic diet as well. I think that that's helpful for people to.
So I have a GAD65 patient who is doing fantastic with ketosis. So you know yeah. So it's not for everyone, you know, but it's definitely worth a try in autoimmune patients.
Okay, great. So here's a bit of a longer question. For patients who have long-term epilepsy following an autoimmune encephalitis, who continue to have seizures that don't respond to medications, what evidence have you seen for the effectiveness? Well, actually, this is the question, ketogenic diet, in reducing inflammation systemically. So you've already answered the question.
Yeah, I mean, in evidence, I don't think there is a large amount of evidence in that cohort. It's more case by case. And I do have patients that it's been very helpful for, but I don't want to say that it's been helpful for all of them. I definitely have some that it really didn't seem to budge. And, you know, some people are just very refractory. A lot of things, they don't budge in their seizure frequency.
Okay. I was curious about this as well. Could you elaborate on musicogenic seizures in this context? Any recommendations how to proceed when certain types of music are seizure triggers, and what test panels are most appropriate?
Very good question. So musicogenic seizures. So it's interesting. different patients have different, and there was a case series on it, and some people it's pop music and things like that. But I treat them mostly just like any other seizure, like we're trying to get their seizures under control. So I don't necessarily treat them any differently. I mean, it depends, like clearly, like, you know, like it's like if someone has a photic sensitive epilepsy as well, and there's certain glasses you can avoid, but I mean, you can't avoid the sunshine or something going through like trees and things. There's certain things you just can't avoid. And so really the answer is immunotherapy and seizure meds to try to get your seizures under control long term. It's just more of a interesting phenomenon that of reflex seizures that GAD65 seems to get.
Interesting. Okay. So somebody comments, great lecture, and has the question, what's the best timing to taper off of an AED in cases of autoimmune epilepsy? How do you go about that?
We don't have a good answer to that. We don't even know who needs long-term therapy. So I'll just tell you what I do, which is what people more senior with more gray hair did. And so I just do it that way. So basically, you know, it kind of depends. So I never wean seizure meds and immunotherapy at the same time, because if you have a breakthrough seizure, you're not going to know which one you actually need. So that's rule number one. And so I essentially, like for instance, that guy I just told you, LGI1 can be monophasic, and we don't really know who's going to relapse and who's not. So in that patient, I slowly wean off. Like for instance, I was giving him pulse steroids so I was giving him like 1,000 milligrams of solumedrol, or sorry, I should use generic names, methylprednisolone, every week. And I just slowly increase the time of the pulses. So like it was like every week and then every other week. And then as you're weaning off the immunotherapy, if they relapse, then you re-pulse them and you give them something long-term. So it depends on the severity too. Now, if they were very severe, like an NMDA, I'll often just continue immunotherapy and everything for about 2 years. That's what most people do. And then try to wean after that. Now, if they get off immunotherapy, things are going well, then I'll probably wean seizure meds too and see if they can get off. And then I usually do a follow-up EEG and see if there's anything epileptiform as well. And then I tell them to refrain, you know, like there's always seizures too. So if they're driving and things, I don't like them driving at that time too. And I discuss seizure precautions and things because they are at risk still for seizures. So I just try to be extra careful in how I counsel patients as well.
Very good.
There was a long answer.
But I think that's helpful to understand timeframes and how to approach this. I think it's a really, especially we think that somebody could come off of an AED and therapy. Right. You do that. There's such a risk in that. So thank you. Here's a different question. Can multiple food allergies contribute to these autoimmune issues? What about the body being in constant state of inflammation?
That's a tough question. So there is more we're learning about the gut microbiome and how it relates to the brain. I don't think we have any specific links. There's a lot of research that needs to be done in that. Some of which is being done at Northwestern actually, with gut microbiome and effect on the central nervous system. But there's also key things like, for instance, like people with gluten and celiac disease, which has like a very well documented neuroceliac and neuroantibodies. So I think the long story short is we don't know. I mean, I don't know how to answer it better than that. There's some links and but yeah, to the core autoimmune encephalitic antibodies, I am not aware of any true clear associations besides for like celiac disease.
Okay. Again, more to learn.
A lot to learn.
And I think we've got time for just a couple more questions. So can you tell us about mast cell activation triggering seizures?
Mast cell activation. So that is, so I would rely, so I'm not, an immunologist. And so I would defer that question to like allergy and immunology, who really treats those patients. And that's kind of beyond my scope of practice. So I don't want to say anything incorrect. So I'll pass on that one. Sorry.
Okay, that's fine. That's fine. So just to clear up a little confusion, what was the drug you referenced to treat your patient? Was it a form of ivermectin?
So no, I didn't. Are they talking about, bortezomib? Is that what they're referring to? Bortezomib is a proteasome inhibitor. Are you talking about the nurse or the patient in the case? The patient in the case got intravenous immunoglobulins steroids.
Yes, and I think that can get confused for ivermectin, which is, we've heard a lot about that lately. So what is IVIG?
So IVIG is, intravenous immunoglobulins. Essentially, when you donate blood, your blood gets divided into, it's essentially donor antibodies, long story short. It's concentrated donor antibodies from multiple donors, and then it gets concentrated and put into an IV bag. So like when you donate blood, there's red blood cells, platelets, clotting factors. They separate it all out depending on what the patient needs. So intravenous immunoglobulins is really donor immunoglobulins.
Okay, great. Complicated. Thank you for.
So basically plasmapheresis, I'm sorry, I should have explained this more. So what I did for him is I plasmapheresed him, taking out his abnormal antibodies. So you wash their blood in 5 cycles. So they're hooked to a machine and you essentially are washing out their antibodies. And then I gave him basically donor antibodies.
Wow.
Sorry, yeah, I probably should have explained what that meant. Sorry. I'm glad you asked.
I'm glad you were able to address it. So we are coming up at the top of our hour. So I will say that this concludes our webinar on autoimmune epilepsy. I want to thank you, Dr. Van Herentz, for a great presentation, and to our audience for some stellar questions. Really, really engaging and really interesting questions. If you have additional questions about the topic or wish to learn more about any of Cure Epilepsy's research programs or webinars, please visit our website or email us at research@cureepilepsy.org. And we know that Dr. Van Herentz has more information on potential treatments for autoimmune epilepsy. And so we're going to try to get him back here next month. So please do stay tuned for more information about that. And also please stay tuned for announcements of our other webinars that will be coming on in the next few months. So thank you again, Dr. Van Herentz. Thank you to our fabulous audience as always. Be well.